Today we're talking about Tirzepatide, Mounjaro or Zepbound, a medication that is rapidly changing how we approach diabetes, obesity, and increasingly cardiovascular disease. This is not just another GLP-1 drug. What makes this unique is its dual mechanism and the magnitude of clinical effect we're seeing across multiple organ systems. By the end of this talk, I want you to understand not just what it does, but why it matters for cardiology. Tirzepatide, marked as Mounjaro for diabetes and Zepbound for weight management, is the first dual GIP and GLP-1 receptor agonist. It is once weekly injection with a long half-life of about 5 days, which makes adherence relatively easy. It's already FDA approved for type 2 diabetes, chronic weight management, and more recently, obstructive sleep apnea in patients with obesity. And importantly, this drug is still early in its life cycle. There are multiple ongoing trials, and we are likely going to see expansion into even more cardiometabolic indications. Mounjaro versus Zepbound. This is a very common point of confusion. Mounjaro and Zepbound are the exact same molecule, Tirzepatide. The difference is the FDA-approved indication. Mounjaro is approved for glycemic control in type 2 diabetes. Zepbound is approved for chronic weight management and obstructive sleep apnea. Clinically, both improve glucose and weight, but from a practical standpoint, insurance coverage is what really differentiates them. Mounjaro is often covered for diabetes. Zepbound coverage is variable and often limited. So, in real-world practice, what you prescribe is often dictated not by physiology, but by access. Mechanism of action. This is where Tirzepatide separates itself. It activates both GIP and GLP-1 receptors. GIP enhances insulin secretion and suppresses glucagon in a glucose-dependent manner. GLP-1 slow gastric emptying, reduce appetite through central pathway, and increases satiety. When you combine this effect, you get a synergistic response, better glycemic control than either pathway alone, and significantly greater weight loss. That dual incretin effect is what drives its superior outcomes compared to prior therapies. Pharmacologically, Tirzepatide reaches peak level in about 24 to 48 hours and has a half-life of approximately 5 days. It's metabolized through proteolytic pathways, not heavily reliant on hepatic enzyme system, which is why no dose adjustment is needed in renal or hepatic impairment. Dosing starts low at 2.5 milligrams weekly and is titrated every 4 weeks. That gradual titration is important, not for efficacy, but for tolerability, especially gastrointestinal side effects. In the SURPASS trials, the glycemic efficacy is striking. We are seeing hemoglobin A1C reduction of up to 2.6%, which is among the most potent effect we have in pharmacotherapy. The majority of patients reach a target of hemoglobin A1C and many approach near normal levels. At the same time, patients are losing significant weight, often 7 to 10 kilograms or more. It outperforms semaglutide at standard doses and even insulin in certain comparison, with a lower risk of hypoglycemia. So you're improving glucose, reducing weight, and lowering risk, all with one agent. Cardiovascular outcomes. From a cardiology perspective, this is critical. In the SURPASS cardiovascular outcome trial, Tirzepatide demonstrated non-inferiority compared to dulaglutide for major adverse cardiovascular events. But when you look at unimputed placebo comparisons, you begin to see meaningful reduction in cardiovascular events. heart failure outcomes, and even all-cause mortality. So, while it meets safety requirement, it also shows strong signal for cardiovascular benefit. This is likely going to become a key player in cardiometabolic risk reduction. The weight loss data is where this becomes truly disruptive. At higher doses, patients are losing about 20% of their body weight, and a significant proportion, about 40%, are losing 25% or more. That is approaching what we typically see with bariatric surgery. And importantly, this is not just cosmetic. This degree of weight loss translates into improvement in blood pressure, lipids, inflammation, and overall cardiovascular risk. But there is an important clinical lesson here. When patients continue tirzepatide, they maintain or even augment their weight loss. When they stop, the majority regain weight, and cardiometabolic benefits decline. This reinforces a key concept: obesity is a chronic, relapsing disease. Just like hypertension or diabetes, stopping therapy leads to recurrence. MASH, in metabolic dysfunction associated steatohepatitis, or MASH, tirzepatide shows impressive results. Up to 60% of patients achieve resolution without worsening fibrosis. This is one of the first times we've seen this level of histological improvement with a pharmacologic agent. Given the cardiovascular risk associated with fatty liver disease, this has major implications beyond hepatology. In heart failure with preserved ejection fraction, or HFpEF, tirzepatide reduces the composite of cardiovascular death and worsening heart failure. It also improves symptoms, inflammation, and renal outcomes. HFpEF has historically been difficult to treat, so seeing benefits here is particularly meaningful. This is where cardiology and metabolic therapy are really starting to converge. Tirzepatide is now the first medication approved for obstructive sleep apnea in patients with obesity. It reduces apnea hypopnea index and improves oxygenation. While weight loss is a major driver, there are likely additional effects on airway structure and inflammation. So again, we are seeing multiple system impact from a single therapy. From a safety standpoint, the most common side effects are gastrointestinal, nausea, diarrhea, and constipation. These are dose dependent and typically occur during dose escalation, then improve. Serious adverse events are uncommon and comparable to other agents in this class. Overall, it's a well-tolerated medication when titrated appropriately. Key contraindications include medullary thyroid carcinoma and MEN2. It should be avoided in pregnancy, and because it delays gastric empty, it can affect oral contraceptive absorption. So patients should use alternative during initiation and dose escalation. Otherwise, it's broadly usable across patient population. One of the biggest limitations right now is cost, around $1,000 per month with highly variable insurance coverage. Medicare does not routinely cover it for obesity, and compounded versions, while increasingly popular, are not FDA approved and carry safety concerns. So access remains a major barrier despite clinical effectiveness. Guidelines are rapidly evolving. AACE, ADA, and obesity guidelines now recognize tirzepatide as a first-line or preferred option in many patients, especially those with obesity and type 2 diabetes. This reflects how quickly the evidence is translating into practice. To summarize, tirzepatide is a first-in-class dual incretin agonist with unprecedented efficacy. It provides powerful glycemic control, significant weight loss, and emerging cardiovascular benefits. Its role is expanding into multiple disease states, including heart failure, fatty liver disease, and sleep apnea. And most importantly, this represents a shift towards treating cardiometabolic disease in a more integrated way. These conclusions are based on large randomized trials, guideline statement, and major journal publication. Always consult your doctor, and this is only for educational purpose. Thank you so much.